Great, thank you. Next, we have a very exciting AI panel led by Julie and Raj. I'll hand it off to you guys, and I'm going to learn a lot in this panel, I know.
Thank you. Thank you so much. We're joined by a really, really wonderful panel here today, and I'm going to go through and ask them to introduce themselves and share what their field is and what their involvement in AI is.
Thank you, Julie, and we really appreciate inviting me to be on this particular panel here. I was actually thinking when I was coming here that actually finally I'm hanging out with the cool kids here. So yeah, it's been a journey with AI, overall, and it's great that we are no longer doing a panel on a Thursday during the cocktail hour. We're actually made it to mainstream, but. I'm Sujay, Jadhav, CEO of Verana Health. Fundamentally, Verana Health, we're a real-world data company at the core. What we do is we leverage AI techniques and help curate data, firstly to provide insights to providers. Some of you may know us as sort of the technical infrastructure behind the IRIS registry. And the primary service that we provide there is sort of MIPS service there. And some of you may not know, but a lot of the quality measures that we actually do there is actually based on AI curation. And so it's something which has been sort of mainstream in terms of leveraging these techniques for a number of years, and we're building upon that. In addition to that, Verana also helps take the data, we de-identify it, and then we provide it to industry to help support sort of insights and research across the drug life cycle. So everything from helping out in protocol optimization, patient recruitment, and all the way to patient journey and commercialization overall. And so, a lot of interesting things which have happened with this particular data. I won't go through it in too much details, but a lot of our data is leveraged for a lot of the innovations, particularly in the last couple of years, such as in the GA arena, and also in sort of rare disease areas like thyroid eye disease, as well. And so, from that perspective, the data, particularly AI as well, has helped in a way democratize sort of how you can leverage it for research, overall. And so look forward to sharing a little bit more of how this data is leveraged further and further, given sort of the AI revolution that we're going through currently right now. I think to just end, a lot of us, have been working on sort of these techniques for a number of years. I've built a really good infrastructure. I think what's exciting is sort of the humanization of AI right now, and working through how can we take what we've done, how we can represent it and support healthcare. Because at the end of the day, healthcare is all about care. And with AI, the humanization element of that is very, very exciting overall, and a lot of us are working on a number of initiatives to make that happen. So.
Thanks. Hi everyone, Nick Pennington. I'm a UK-trained neurosurgeon by background, but now run a company called Ufonia. What we do is we use AI to automate patient visits. And so that's actually something that wasn't on Long's slide. It's actually the physician visit. So we're physician labor replacement, which is, I guess, still a bit controversial. But in the UK, we've delivered nearly 200,000 visits, almost all in ophthalmology. We just signed a contract to deploy and deliver about 1 million more over the next 3 years. We've been live in Texas, down with some academic medical centers there, since the start of the year, and actually on Monday of next week we go live in our first commercial ophthalmology practice out in California. So I guess I have a sort of super bullish view on the future of what AI can do, and I think we're all going to have to sort of think differently as we move forwards about what our role as physicians, surgeons are in the ecosystem, because the potential of the technology, I think, is pretty profound.
Thank you. Blake Anderson. I'm a practicing internal medicine doctor and data scientist and software developer now. Had a number of roles over the years, machine learning research, did some admin roles. I was chief health informatics officer at one of the VA facilities, spent some time in the National VA. Ended up landing on becoming a software vendor. Founded Switchboard MD, where I'm CEO and CTO. Still do probably too much of the coding at this point. But what we focus on is how can we make it easier for doctors to be doctors and for patients to be patients, to put it very simply. There's a lot of administrative tasks that we can make a lot easier and run smoother. One of the jokes I tell one of my best friends who's a cornea and refractive surgeon is, how can we make it easier for you to shoot lasers into people's eyeballs and stuff? And so that's kind of, very simply what we focus on.
Thank you. Daniela Ferrara, I'm a retina specialist, imaging expert and clinical trialist. I currently serve as CMO for Topcon Healthcare, where I oversee the clinical science, clinical affairs, and clinical operations for clinical trials for drugs and for CMD cleared algorithms. We have 3 very clear goals. The first one is to enable technologies for oculomics research, leveraging ocular data to improve predictions for systemic health. Second goal is to connect real-world data to clinical trials. We can't push the science of oculomics fast enough if we don't leverage all the wealth of information that we're collecting at the clinic right now. And similarly, we can't improve clinical trials if we don't fully leverage real-world data. So with that, we want to use real-world data from end-to-end in drug development, from better disease characterization to efficiency in clinical trial conduct, accelerating finding patients and managing them in real time, all the way to digital twins and synthetic control arms that were discussed in previous sessions. The last goal sounds not so cool, but is equally important. We need to commit to data standards in ophthalmology. This has been a bottleneck for the development and implementation of AI. And our organization is working with AAO, CCOI, and other global organizations to commit. It's about time that ophthalmology needs to move to data standards. We're 2 decades behind radiology.
Thank you. My name is Roshni, Bhagalia, and I lead digital products in the surgical franchise for Alcon. My background is, more computer science and machine learning than I think the rest of the panel here. But the focus at Alcon is 3 things. Apart from driving internal efficiency, so we use AI to make our own processes simple, right? To make our own coding better, to make our own manufacturing lines more optimized and our devices more accurate. Apart from that, we also want to drive operational efficiencies for our customers through our products, right? So as you know, Alcon and our partners have many, many different steps in the workflow for ophthalmology, and every one of those steps can be simplified both from the operational side as well as the administrative side. And so Alcon is investing both internally, but then also through partnerships and deals to try and see how we can simplify that entire process. And then the third focus area for us is really driving clinical outcomes, right? So how do you get to more precision, more personalized medicine using all the data that we can collect? And I couldn't agree more with Daniela about, the more we can standardize the data and the more we can make interoperability between the systems all the way from devices, EHRs, but then also over time, social media, to really get to the point where you can really understand what a person wants and how the person has lived. It's really going to help us drive better outcomes. So those are the 3 things that Alcon's focusing on.
Great, thank you all. Yeah, as you can see, we have a mix of industry perspective as well as clinical perspectives, and that's how we're going to try to guide this discussion. But I think if we start with perhaps data, Roshni, Daniela, Sujay all mentioned it. In terms of who owns the data, what will be done with it in the future, how can it be applicable to those beyond where it's actually collected. And certainly we're seeing that in the robotic space. There's so much intraoperative imaging data that's collected. But I did want to just make one comment, because workforce is also a big part of what's going to happen with AI and the concern regarding changes for that in all fields, not just ophthalmology for sure. But I think in the future we may not need moderators. Julie and I talked about whether we could have bots just asking the questions here to continue the discussion. Hopefully we'll do better than that, Julie. But maybe Daniela, we'll start with you.
So I'll start acknowledging your question has so many layers. I'm going to focus on the more technical scientific side, but I will acknowledge that data governance, data ownership, regulations, all the way to cybersecurity, all of this needs to be solved so we can properly develop and implement AI-based solutions. Now, the sentiment where we're coming from is, for better or worse, healthcare is the last sector of economy to implement AI. And let's be clear, is not that, for example, drug development is working. Our success rates is single digits. It takes more than a decade to take one compound from bench to bedside. Healthcare system is failing patients. Patients going blind without even knowing their diagnosis. So that's the premise, is we need to collectively implement carefully and ethically and safely AI. Now, specifically for the data, I think you touch a clear point. Data harmonization is one aspect. Interoperability is probably the second most technical challenge. Our systems don't talk to each other. And we are starting, our organization is starting from OpenDICOM for images, but then we have to connect with EMRs. That's another huge challenge. And then we have to connect with omics. So data standards is definitely the task at hand to make all of this possible.
Yeah, again, I'll just add to it. I mean, actually stepping back a bit, when you look at sort of AI and how ophthalmology is overall, and I think it's absolutely ripe for innovation, overall. And I'm not saying that because we're surrounded by a bunch of ophthalmologists here and I want to exit the room in a clean fashion, but we at Verana also work in some other therapeutic areas like urology, oncology. We can compare and contrast. And there's a couple of dynamics around ophthalmology which are very data-centric, and it's actually unbiased data. So first and foremost, every particular specialty has real-world data. It's based on the EHR system. But I think the differentiation here is the amount of imaging data that ophthalmology has. And it's actually an unbiased data source. And so a lot of us are leveraging that a lot as an input in terms of helping drive these particular insights, overall. The other dynamic is sort of the variability in ophthalmology is incredible, right? So left eye, right eye, back, front, etc. The number of variables that are in play when you're actually measuring and trying to understand the progression of disease is enormous, and that's where AI is very, very ripe in terms of helping innovate and drive sort of efficiencies there. But when you look at the data and sort of the question on who owns the data, ultimately, obviously, the patient owns the data. I will say in terms of sort of the infrastructure in place right now, the security, I actually feel we're quite mature there. And most of the issues in the industry are really around adoption. And so, taking patient data, transferring it obviously to the physician, then going through the process of de-identification. This is stuff which has been happening for a number of years. And then that has facilitated taking these data sets and using token systems to basically actually marry that up with other types of data sources outside the clinic, like claims data, imaging data. An area which actually is growing quite nicely and is providing that next level of insight is genomic data as well there. So I would say that actually the security is actually very, very mature. I think most of the focus right now is really around adoption and getting people comfortable around it. And that's the beauty of AI, because I think there's this human element to AI can make it very, very tangible, which can actually accelerate sort of the use of this throughout the overall value chain.
That's really, really interesting, and great points from both of you. I think that, once we start talking about compounding data from so many patients from so many places, how do you, these algorithms are trained on this data where it comes from. How do you, how does that become a company's property rather than the patient's property? And what are the implications in our society when, you can't, AI is nothing without a training set, right? You have to have this to learn from, and you have to have it to be able to identify from. Where does that line become between being patient's data versus being company data versus being AI data, and what does that look like?
Yeah, maybe I'll take a quick stab at that, right? So, I agree with the panelists here that eventually the data belongs to the patients, right? But in order to harness that data, apart from standardizations, you have to make sure that the data is sanitized, right? You have to make sure that the data is cleansed, that there's a certain level of quality in the type of data that you're capturing. And then not just that, you actually need all the data elements to be correlatable, right? So you almost have to build a data model where you're creating and collecting all the pieces of that data, and then eventually also the outcomes, right? And so I would argue that, while the data belongs to the patients, the work to harness that data and then get insights out of it and then crystallize it into an algorithm actually belongs to the creators of the algorithm, right? That's intellectual property that belongs to the people who took all the effort to formalize what type of data should be created, to get that data in a holistic manner, and then apply technology on top of it to get those insights. So that's where I think the line is.
I think there's a sort of a practical and a philosophical question about it. The practical question becomes, I think, less and less complicated as we go forwards. I think the ability to, one of the biggest challenges that I saw as a clinician trying to do sort of research work is how do you get hold of this information in a standardized way, right? Because you've got these, really messy, soft, squidgy humans in the middle, right, who are asking patient questions in different ways and putting it into the record differently, and they're using it. There is a tremendous ability to standardize that with technology. So practically, that's point one. Point two in the practical sense is these sort of classic systems of record, which have been like black boxes and very difficult to penetrate and to connect together. Again, that's really tremendously changed, even over months and if not a year or two, with some of the tools that have now been developed using AI to be able to understand data and transform it. So I think practically we're in a really exciting phase. Philosophically, in terms of the patient side of things, I think I would stand behind the view that it's my data if I'm the patient, but our practical real-world experience, we ask every single patient on every one of the conversations that we have with them, AI conversations, are you happy for this to be used for training and for research? And the overwhelming majority, 90+%, say yes to that. Because it's a sort of trade-off, right? Most patients get it. We don't have to think too hard that actually if they share some information in their care is going to be better, their relatives' care is going to be better, other people philanthropically that they sort of want to look after, their care is going to be better. So I think the reality is most people are quite happy to share it. They're intimate, identifiable information, but generally they're non-identifiable, de-anonymized information for improving how we treat society as a whole seems to be pretty acceptable to most people in our experience.
I share the experience because coming from the clinic and coming from a decade in big pharma and clinical trials for drug development, it's interesting to see patients understand that their data alone is not going to contribute to science, but if they aggregate their data with all the other patients' data from that organization, then they understand the impact and the relevance for society. And it reminds me a lot of the conversations that we have when we invite patients to join clinical trials. They understand that they themselves may not benefit from that drug or that molecule, but they understand they're contributing to science. Now, I think equally challenged to manage patient understanding and education, surprisingly, has been to manage adoption by clinicians. And again, coming from the challenges from the clinic, it's been interesting to see the evolution in the last few years. I agree, we used to be the weirdos and the distractions, and we used to be in a satellite room talking about something that it would delay patient management or clinical trials, and now it's a must. But what happened is, I think we came as a community to the conclusion that we need more efficiency and we need, so I don't see a scenario that AI will replace experts. It will, and it is already completely changing how we interact with the patient and how we interact with clinical trial data, but it's not going to remove the need for an expert. AI is just a tool.
That's really, really great discussion, really, really excellent points. I think we should move on to another topic, though, and that is kind of echoing the trust that came up, how are clinicians going to respond to having AI in our clinics? How are patients going to respond to that? And, at first, personally was kind of incredulous about this, but now, I live in San Francisco. Waymo is my preferred way of transportation. I literally prefer a robot driver to a human driver now. Do we see that happening in the clinic? Like what, Nick, let's start with you. You're probably interfacing with this most directly.
Yeah, I mean, we think the Waymo autonomous car industry is a pretty significant precedent for what's going to happen in healthcare. As was mentioned, healthcare is probably the laggard, for all sorts of very sensible reasons in terms of transforming. Our model of care delivery has probably been the same for the past century, if not more. But that is changing, and I think, as other industries move around us, that will change. But patients expect it. I think the surprising thing is you can believe your own hype a little bit too much as a physician, as a surgeon, that patients really want to come and see you for their day one cataract visit. And I can tell you from actual empirical evidence, they don't. They really don't want to get in the car or get their daughter to take them in the car to come in, if they know that they're well. And so meeting people where they are and providing a kind of convenient experience that they're getting, like with Waymo, in the rest of society, is the challenge for us all to try and think, how do we embrace that? And the expertise is right, but the expertise is not the expertise that we see today. So what we think of as expertise today is not what expertise needs to be in 5 years' time. It's a different level that we need to be performing to, and we need to be kind of proactive about that. And think, not just let it happen to us, but be intentional about deciding what we're going to take on and what we're going to use technology to deliver a better, more convenient experience for patients.
And Blake, maybe you can comment on how your experience has guided this, but also as we're talking about this, since we're talking about use cases, maybe we should also incorporate, and we'll talk about this perhaps later in the day in terms of the regulatory process, but how is that going to impact what becomes available and how we will find a path through it? So maybe...
That's a great question, and again, I think we as a community will need to co-create. Use cases are absolutely critical. Those devices, when they become available, they are becoming available at the point of care as well. So it's very different to run an AI-based tool in a clinical trial where it's a very controlled, safe environment for the patient. It's very different to run that in a busy clinic. But at the end of the day, if it's an output that improves patients' outcomes, that's what we're trying to achieve. Now, to the use case, there are two very different types of algorithms. There are algorithms that bring efficiency. They find biomarkers we know, they point them out, and they measure. So it's very comfortable for a clinician to overwrite the algorithm if they don't trust or they think they don't apply. It's an easy conversation with the patient as well. It says, I see here, that's your lesion, that's the information that I'm going to use to treat you. I'm very curious to see how we all will behave when we move, and we're getting there, towards algorithms that we cannot understand how the output was created. So the black box dilemma continues to be a challenge for adoption. But those are the most powerful, though.
Can you repeat the question?
Just how are you seeing in practice, since we're talking about kind of the clinical aspects of where AI is impacting all of us in clinical practice, how your experience with what you've developed has kind of guided that, or what you see happening in the future?
Yeah, so we have focused more on some of the administrative tasks, trying to make it easier. And I think in a lot of ways it ends up being easier for many of the patients, because if the choice is wait on hold to speak to someone for 30 minutes and they're just following questions off of a spreadsheet, or you can speak with an AI voice agent and get the same thing accomplished in 2 minutes, many people will choose that option. And I think some of the other kind of less glamorous things that we've had a lot of success with, trying to make it easier to go from point A to point B for that patient to the care they need. So things like, when I as an internist am faxing over a medical clearance document to the ophthalmologist just to say, yes, if you can do this surgery. And then it goes to one of 50 different fax lines. Nobody knows which one does what and where they are. We can make it easier and make it so that that patient doesn't have their surgery canceled. That's a huge value for everyone involved, the patient and the doctor. And I think that focusing on those use cases and getting those incremental benefits, I think is kind of the most important part of it. Dirty secret of healthcare, everybody probably knows, faxes are still used, it's terrible, they're never going away.
One of the things that, that I'm curious as we kind of start seeing more and more AI in clinic is the trust issue. How do you build trust with clinicians? How do you build trust with patients? Blake, how do you know, how do you convince people that when the fax goes through, it's going to be routed to the right place? Or if the patient calls in, they're accepting that they talk to an agent and not a real person? And Nick, for those post-op day one visits, how do patients, do they know that they're talking to an agent versus a real provider? And how do you reassure them, and the people you're signing contracts with that this is going to be the right thing?
So as far as the trust goes, it's becoming more and more necessary to do this because the AI voices are getting so natural, you could very easily fool someone into thinking you are speaking to a human. And so we very clearly say, I'm an AI voice agent, and we give the person the choice always to speak to a human operator. And so we do have some patients who call in, and they'll just start yelling operator, just like jamming 0 or pound over and over again. And we honor that, we pass them along. They may have to wait on hold for a long time, but I think it's important to do that. And I think some of the other important pieces are, having a human in the loop when necessary and having a lot of kind of retroactive validation and clinically making sure that everything is good and making sure that the AI agent isn't doing like something weird or saying something inappropriate and having that audit process.
I 100% agree on the trust issue. I mean, I think that's the point about why the profession is sort of a laggard in one way, but in a positive way, you could see that as just about having a high threshold for trust. It's the be-all and end-all of what we do. So, our research is about how do you build the safety frameworks for AI delivering clinical care, inspired highly by the autonomous car industry that's sort of been through this cycle, a number of years ago about effectively defining what are core behaviors. So we have a paper in Nature Medicine at the start of the year about saying it's not just about the stuff that I think probably gets quite a lot of the news cycle at the moment in AI of can it make diagnosis, can it read the New England Journal case reports and make the right diagnosis from it. There's an article yesterday, I think, in Science from the Boston group as well, showing that, look, even models that are now 6+ months old can do that better than their clinicians in the Mass General group. So that's part of it. And I think the trust on that, people are kind of moving towards. The other part of it is what we would call care behaviors. And so can people trust the care behaviors? Do they trust that the system has their interests at heart, that is empathetic to them as well as just technically capable of transcribing what they say correctly? And so building that up, and our particular view of that is, well, we build it up, we publish that information, we get the trust of the clinical community, and still and forever, patients will look to their clinicians as the arbiters of trust. No, very few patients are looking and reading the primary evidence in the literature. They're looking to their clinicians. So I think that's the same for AI, is that they'll trust the people who say, we've adopted this tool and we think it's safe for you and it makes your care better.
If I can summarize what I'm learning from the panel, there are 2 words: transparency and education. AI is a new technology like so many others that we've adopted throughout our careers in clinical research or practice. And the implementation is increasing so fast, that's very confusing right now. There's so much noise, so many options. And I still have colleagues that use none. I don't know how they do this, but they still don't use AI. And I have others that are trying like a recent grad student, and they are learning a lot, but they're also very confused. So I think the piece of the education is possibly a missing link.
Yeah, and just to add to it, I mean, we're also now moving up and focusing on the provider and seeing how they can use and leverage AI to improve the way they do things as well. And it's been a journey, and I'm very thankful, for ChatGPT and open evidence. And I think there was just a massive transformation when that occurred, where all of a sudden it became mainstream. And while all these techniques were available prior to that, that actually transformed things in terms of people being willing to do it. And initially, we approached it by taking certain processes and said, we're going to automate that completely. And we wouldn't get buy-in on this. And people said, no, you're going to take my job away. So we very quickly moved to being more of a supportive function. And sort of focusing on sort of deterministic types of processes where, for a set of inputs, you get an exact output to give that confidence level. And so, as I mentioned, we do MIPS, and when you calculate your quality scores, that's a perfect deterministic process. And then over a period of time, exposing them to, hey, look, there's this gap in care, gap in documentation. If you change this, then actually you'll get a better score. It'll lead to better rebates that you get, and that can be tens of thousands, if not hundreds of thousands of dollars. And so we're in this journey sort of helping move them up into probabilistic sort of scenarios there. And ultimately seeing how they can optimize these processes. But it's definitely a journey, and we're doing this sort of an incremental approach. And definitely the human in the loop element is something that we've had to insert quite a bit throughout this particular process as a backup, but actually more as to actually get that particular buy-in as well.
So maybe let's transition to what the future holds. Obviously, we're all here because of innovation. And so from the industry perspective, how are you seeing AI being used differently now beyond clinical trials? Of course, we've had some discussion about that already, but where do you see this impacting how you would do things differently and what impact that will ultimately have for us in the clinic? Roshni, if you could start.
Yeah, sure. I think we've talked quite a lot about sort of customer-facing use cases, and I think they're very important. But a lot of the things in the industry are also on the internal side. Right, so there's speed to market, there's how do you code better, how do you make your manufacturing lines more efficient, how do you actually get rid of some of the administrative burdens even inside a company, right? And I think a lot of companies, not just Alcon, are sort of embracing that. You've all probably heard of Claude, you've heard of ChatGPT, but coding used to take 6 months. It now can be done a lot faster with the same level of fidelity and the same level of accuracy. There's also the trust factor, right? But the more you do that, the more you can drive internal efficiency. So I think, all industries, not just eye care, are going to that path, right? Where compressing the cycle from having a really cool idea to putting it out into the market in a very compliant manner, but with the same level of quality, right? So that's one area. The couple of other areas that I think industry is going to start focusing more on is actually the lower hanging fruit, right? Because that's where you build the trust. So all the things that the panel was talking about, which is, take away the administrative burden, take away sort of the simple things that they add to my day, but I trust that somebody else like AI can do it because I've worked with ChatGPT, because I've seen things like open evidence, and they're now in the realm of possibility. I feel like the more we do that on the industry side, that's how you get your foot in the door and get to that trust factor. Whereas a company, you're seen as, and not just seen as, but are sort of a trustworthy, responsible company that's bringing AI into the workflow. And then in parallel, we're working also more on the clinical decision support side of things, right? So because that is the higher barrier to entry, that is something that has and rightly should have the higher burden of proof. But once we can sort of simplify the administrative tasks, I think then the next horizon is going to be, how do you get to that clinical decision support with the right level of trust? And I think you can look at, even in healthcare, adjacencies like radiology, right? Radiology has sort of gone over the hill a little bit in that front because they've built that trust, and they've shown, even if the model is not transparent, because it works so many times and it got their answer so many times, and there's so many people giving word of mouth, that AI has become more mainstream in that process. And it's really through looking at colleagues and looking at other case studies that I think we're going to drive adoption.
I love it. I really share your enthusiasm for the efficiency. Patients don't have the luxury of time. They're going blind as we speak, and efficiency does influence better outcomes in clinical research and, of course, in clinical practice as well. So to balance your very pragmatic excitement, I'm going to choose a forward-looking piece, which is back to the oculomics research. This is still very early ages of this new scientific field, but any ophthalmologist in the room like me has been doing oculomics without the fancy name. I lost count of how many patients I looked into their retina and I said, you have diabetes, you have high blood pressure, go get your neurology exam checked because there's something wrong with your optic nerve. We've been doing oculomics clinically for decades, but now we can do at scale and we can do with much more confidence because of AI and the ability to analyze complex data sets at scale. So oculomics has the potential, if we get that right, to address a very critical challenge in healthcare, which is the fragmentation in the patient journey. So we have patients in the primary care setting, we have patients in primary eye care setting, we have patients in specialty eye care setting, and we have patients that are just out there excluded from healthcare system. If we can find those patients with reliable, reproducible predictions and help the patients to navigate healthcare, yes, it's pie in the sky, yes, it's going to be hard, but it has the potential to truly transform healthcare.
Keep going, or next question, or are we going to keep going?
I think the one last thing that I wanted to visit, and we're seeing this happen right now, I think in tech, at least in San Francisco, with a lot of layoffs coming because people's jobs are being replaced by AI coding. Do we foresee a workforce in the future where physicians are not necessary, or industry is not necessary in a way, and where do we are we going to replace ourselves with computers? What do you think the role of the clinician in the future is going to be going forward?
It's come to me because I'm presenting, I guess, the kind of bold view here, but I'm going to, Raj is on the panel, right, from Horizon. In terms of changing how we do stuff. Look, I think it's change, right? Change is inevitable for everybody, and it just is a question of the speed of change. And the speed of change at the moment just feels very fast in this particular space and in other industries. I'm really happy that a combination of demographic shift, non-demographic factors about the ability to diagnose disease and treat disease means that no physician's going to be out of a job anytime soon. So I think that's taken us red. But we just are going to have to do things differently. We are, I completely see a future where cataract surgery is a highly automated process. But that's a bit like saying a chemical pathologist, used to count the red cells on a slide, right? And now they don't do that anymore, and they work at a much higher level of their license. And I think, it's an extreme example, but that's what we've got to embrace. I mean, my daughter's 16. And I think what's like the future of her job, career, and it's definitely different from when I was 16. And I think that's got to be the same for healthcare, right? We've got to think about what we're going to be doing as ophthalmologists or physicians, generally, and we're not going to be doing the same thing. But the point is, we've been able to it's a little bit of boiling the frog going on, because healthcare is being able to sort of keep carrying on. But suddenly, the pace of change of the technology means I think we're just going to have to be proactive on it rather than reactive.
Yeah, so a couple things. I think we still have time. I think that there's still a large gap between being able to take, the USMLE and answer a multiple choice question and actually diagnosing a real patient in front of you. It's just, there's a huge gap there, and we're not quite there yet. I do think that physicians are going to have to get more comfortable with interacting with AI, obviously. And people may or may not know this, but doctors don't really like being told what to do. And so finding a way to incorporate it into the workflow naturally, where they don't hate it, is kind of important, and really is kind of the responsibility of industry to incorporate into the workflows naturally so that we can actually make these advances and make them actually useful.
So we have less than 4 minutes, and we're not going to be the first panel to break Gil's rule of going over time. So we have about 30 seconds each. I know it's hard to do this, but what do you think is going to be most impactful, either from the industry perspective, innovation perspective, or clinical aspect with AI? So 30 seconds, just kind of few words. Roshni?
I think the most, you mean the most impactful change in ophthalmology with AI? Is that what you mean?
In the next few years.
In the next few years. I think two things, right? I really think simplifying I know it's not sexy, guys, right? But it's simplifying the operational efficiency, right? So really taking out the double entry, simplifying that workflow, having all the right information at the right time for the right patient. I think that's really going to be transformational. And then second is actually the multi-omic side of it, right? Like if we can crack that nut, then you can really open the top of the funnel and imagine having really good patient triage, personalized right in the beginning. I think that can be transformational.
Love it, yeah. So since I started from the forward-looking, now I'm going to be very grounded. We're connecting real-world data to clinical trial data. That's what's changing the field already. And I'm going to leave with the sentiment, what I tell my students in academia that don't want to get the AI in there day by day, I tell them, this is like GPS. I challenge you to go out through that door and walk around without your GPS. That's what this first wave of algorithms are doing for clinical practice and clinical research.
I'm going to take a slightly different approach here. I think the most significant is going to be potentially some failures as a result of over-reliance too early on some of the AI things. Just like being able to answer questions is not the same as actually interacting with a patient. Using a coding assistant is not the same as building enterprise-ready software. And I think there will be failures that come as a result of people who are overly confident in what they're producing, which is really just an MVP, Dunning-Kruger effect, essentially.
Tangibly, there will be end-to-end automated cataract surgery visits and surgery. I can't tell you how soon that will be. And to Gil's point, most importantly, CMS will pay for it.
Yeah, I'll repeat sort of, I think the humanization of AI, I think that's extremely exciting overall. I think it's the first technology which actually has that element which can help augment the way actually we do patient care overall. So I'm excited about the implications around that.
We have 1 minute left, so I'm going to put in my piece real quick. I think it's going to be developing a system that really individualizes patients' care so that the patients feel like they are taken care of every step of the process, which I think our healthcare system is uniquely bad at currently. Raj, back to you.
Well, I'll just thank the panel. I mean, excellent comments, discussion, and I'm sure we'll have a chance to interact throughout the next part of the meeting, which is a networking event or networking time, a break, and then make sure you're back by 10:15 for the drug delivery session. Thank you very much.
Thanks.